Welcome to section 3 of Deep Tissue Massage, a video guide to techniques. In this section, we will cover the basic problems that most massage therapists encounter in their practices as far as injuries, people that are complaining of pain or want better performance through better flexibility. There are going to be a lot of strokes that I've previously shown in particularly the second section, the strategies section, that I'm going to work rather quickly through, and I do want you to remember that I just don't want to repeat all of these strokes in their entirety, but that particularly working with injuries, you must work very, very slowly and cautiously and work within the constraints that your client's body is going to present to you. It's important to remember when you're working with injuries to not put too much pressure on yourself. Remember, we aren't doctors, we aren't chiropractors or osteopaths, but we can still accomplish a great deal of benefit to our clients. And so it's important for you to know your limits, realize that we cannot diagnose injuries or conditions, but also realize that even if, and this is very, very important, even if we can't directly affect a particular condition or injury, we can give nurture to our clients, we can calm their central nervous system and put their body in a better place to heal itself. Working with injuries or conditions of pain is a bit of a two-edged sword. I find the work tremendously rewarding and interesting and challenging, but there's also the problem of working too hard and trying to help your clients too much and actually setting them back. So I do want to issue this caveat. It is much better to do too little work than it is to do too much work and set your client back. So don't be too hard on yourself. Remember, we aren't doctors and we don't have the responsibility of curing our patients. However, our clients can greatly benefit from just the relaxation of getting a massage. One of the goals that I want you to be able to do is, if you have a client that's injured and you don't know the proper way to necessarily cure that injury, that you can work around that injury very, very safely without shying away from it. One of the things we have to do as therapists is to bring our clients awareness. They may disassociate or in other ways block off their areas of injury. So don't be too hard on yourself. Don't judge yourself by the success of alleviating pain from your clients. Sometimes the work you'll do will actually have a large benefit that they may not be aware of or that may manifest itself days or even weeks down the line. I'd like to talk about taking a holistic approach to your client's problems. One of the complaints that I've had watching some other videos about how to deal with injuries, and an often cited complaint that some of my clients come in and talk about with Western medicine, is the sort of myopic or short-sighted view of just looking right at the site of injury or pain and working from there. The psychological mindset of your client dealing with an injury is a tremendously important thing that you have to deal with, and I think that we give scant attention to this in our trainings. Expressing your compassion for the psychological issues that are associated with injuries can be one of the biggest ways you can help your clients. Very often they feel very, very lonely and feel like they're deprived of that aspect when they've been treated by a doctor who's allowed 5 or at the most 10 minutes to talk to them. So let's talk about some of these psychological aspects that you will encounter with injuries. Number one, I would say that I deal with is fear. People have a tendency to not have confidence in their own body's ability to cure itself. And I get calls late at night from people that have suddenly fallen down the stairs and want to come in at 8 o'clock in the morning before they even have any idea how their body may react. And so that fear can really contribute through holding patterns and other issues that will hamper the recovery of your client. If you can address those things without trying to be a psychologist and let the person just be free to express whatever they want to express and just be compassionate, give them an optimistic view of their recovery without being unrealistic, and have them let go of some of the meanings that these injuries have for them. Many of us, through our activities, define ourselves as human beings, and if we're unable to run, if we're unable to perform our work, if we look at chronic injuries as a sign of old age, then there are many, many other factors with these injuries that need to be considered. So please do consider this when you're working with your clients. Other factors might be anger. People that injure themselves at work or have to deal with unresponsiveness from their bosses or from their loved ones. This is another emotion that you must deal with, and that sometimes letting these emotions out in a safe place with you can be a very, very important part in their healing process. Clients who are injured often feel isolated as well. It seems like everybody else in the world is pain-free and able to function at high levels of activity, and this is another thing that you're going to need to deal with. Along with this also comes a feeling of lack of empowerment. They can't seem to do anything to make themselves better. And I found this has been an extremely rewarding and effective part of my practice, and that is working with clients to empower their own improvement. It may be tempting to have a client see you 3 or 4 times a week after they've had an injury, but if you can get a knowledge of the human body, look at a sports medicine textbook or something like this to talk about some of the things that these clients can do at home, strengthening exercises, flexibility exercises, going to yoga classes, things that they can stop relying on other people and pills and surgery to work with. This is a tremendously important aspect. So the limitations of time with this video have prevented me from showing a lot of the ways I deal with this. My book actually covers a fair amount of strengthening and stretching activities, and as I mentioned, sports medicine books will even go into more detail. I will give you a couple fairly brief examples in here, probably with the shoulder girdle and with the knee, to show you how you might work with your client in strengthening. But I would strongly suggest that you add this as another dimension to increase your effectiveness and expertise. I'd like to talk a little bit about PNF stretches, which stands for proprioceptive neuromuscular facilitation, which is sort of Western medicine's way of making things unintelligible for the masses. It's a very useful tool, and I would strongly suggest that you take a class that will go into much more detail than I have the time to go in here, particularly sports massage classes utilize this tool a lot, but I will be occasionally utilizing it throughout this tape, and I want to at least let you understand a little bit about the principles of this. Basically, PNF stretches can also be called contract relax stretches, and it has to do with resetting your stretch receptors in the muscles. If a joint is sore or if a muscle's been pulled and it hurts through a certain range of motion, your stretch receptors in that muscle are going to try to alert the joint that it's nearing a range of motion that's painful. And over time, if you have an injury over a long period of time, your whole range of motion will be restricted. Other things such as specific sports activities or work activities that tighten muscles will prevent the range of motion from working as well. So it doesn't have to be an injury. So I'm going to use Dina's shoulder here to demonstrate a little bit about PNF stretches. If I move Dina's humerus or arm into external rotation, she's excellent. Dina is a backstroker. This is a motion that she's going to need a whole lot of mobility in, and so she's got a lot of mobility here. There's no need for me to increase her external rotation here, and it might even harm her by making her hyperflexible in a vulnerable position. But if we move her into internal rotation with her humerus coming straight out from her body, you can see that she's limited here. She only goes to about here if she lets gravity take over, and I stabilize her shoulder so that it's not moving up. So all I'm going to do with the P and F stretch is I'm going to move her to the end of her comfortable end range. And I'm going to notice, how does it end here? Does it come in a rather sudden, sharp end, which would indicate possibly ligamentous or joint restriction? Or does it slowly come to an end, which would be more muscular? And that's where this is the most useful, using PNF stretches. So hers comes to a rather slow end range, and then I feel the joint coming in, and I'm not going to force that. You don't try to force this because the stretch receptors are going to fight back against you. So once I have Dina's arm rotated internally to its comfortable end range, all I do is hold her at her end range and ask her to just gently meet my pressure, raising her hand to the ceiling against my resistance. This is very important that you tell her not to try to overpower you. Just begin slowly and meet your resistance. Then, after she has resisted for about 6 seconds, take a nice deep breath, and slowly she's letting go. It's very important that I'm not forcing this. I'm putting maybe about 5 ounces of pressure at the very most. So now we've sort of redefined that a little bit, and I'm going to have her do this one more time and raise her arm up against me and just meet my resistance. Wait about 6 seconds to fatigue out those stretch receptors, and then take a nice deep breath, Dina, on the next breath, and on your out breath, just let that go. And you slowly work with her letting go. Again, you're not forcing this. So then I'm going to let Dina's arm just sort of recover, shake it a little bit. And let's put it back out here, and let's see where it rests now. So this is significant. Now maybe tomorrow she might be back up to here, but what you've actually done is you haven't just stretched a muscle, you've redefined some neurological processes so that she's going to have more mobility. And you can do this on virtually any place on the body that a muscle is tight. Okay, let's move down to Dina's hamstring to give another quick example of how this works. So the hamstring, it's very important when you do the hamstrings that you keep the knee straight, because if you bend the knee, then the hamstring's going to be shortened here and you're not going to really be stretching it. So I just bring Dina up to where I feel resistance, and I'm starting to feel it here. Hamstring's a very safe joint. You're not going to be straining a joint by going farther. So I'm going to go to just about here, which is short of vertical. And this is actually pretty good for most people if they can get up here. But I'm just going to hold and take care of my own body mechanics and have Dina push down against me. And just meet my energy. Don't strain that. Now you can push a little bit harder. That's good. And just hold that. Take a nice deep breath. And just let that go. And let's try that one more time. I'm doing this a little faster just because we have so much to cover here. I would probably let her adjust to that a little bit, and push a little harder again, and just relax. Good. Again, I'm only pushing maybe half a pound here. This is a lot safer joint, so I can push a little bit more. Maybe I'm up to a pound here. And then I'm going to bring her leg down, test it. The good thing about this is your clients will notice a difference immediately and see how effective this work is. And now we can see we can get her just about up to vertical before things start catching here. Let me give you just one more quick example to show you the effectiveness of this, and you can imagine all the other areas that you could probably be using this. Let's just show one more example of a PNF stretch to deal with the rotation of the femurs. So if we look at Dina's legs as I bring them up here and bring her knees so that her lower leg is vertical, and I let her put her legs out and just let gravity dictate, we can see that Dina's left leg is not as mobile as her right. And so that might mean, since she's moving into internal rotation here, that the external rotators are a little bit tight on this side. And we've already talked about how to work on the external rotators in this way, but I want to just show with the PNF stretch the effectiveness of this. So what I can do is have Dina just put her other leg down, just so it's easier for her. And you always want to be careful when you're working this way that you don't strain the knee. So I always ask people how their knee is, and I move very, very slowly to make sure they're safe. As long as their knee's at a right angle here, it should be very, very safe, okay? So all I'm going to do is move Dina to her in range. And I feel the muscular component really stretching here, so her external rotators are a factor. They are going to loosen up when we do this, but then at the very end it comes to a rather sharp halt. So that indicates to me that her joint is also involved a little bit. The ligaments may be a little tighter. Her osseous component may be a little restricted there, but I'm going to put her down to her comfortable in range and have Dina be sure and tell me if she feels any strain in her knee. If she really does feel strain in her knee, I can work the whole knee along with this, but just so you can see what's happening, I'm going to do it this way. So I'm going to have her in range, and she's going to resist against me. So I'm pushing in this direction, she's going to be pushing in that direction. Okay, Dina, just go ahead up against me and start a little slower. Particularly with the knee joint, you want to tell them to start very slowly, and a little bit more force if your knee feels okay with that. And I'm going to wait about 6 seconds, and Dina, take a nice deep breath, and just let that go. Oh, and she's letting go very nicely here. I felt that in range in the joint, so I wasn't too confident we were going to get as much of a release. But that feels very good. I'm going to do one more here. And Dina, come on back up again and resist. Great, great. And hold that. It's very important here that you be satisfied with a degree or two. If you overwork this, they can be sore. Okay, nice breath, and on your out breath. So you're not going to necessarily make sure that this leg is perfectly matching with the other leg. The main thing is that you increase the mobility a little bit. So let's test this and just see with gravity how that's going to work. Okay, just let them go. So actually that was very effective. So this is a great tool. Do use this in your practice when you start working with specific issues that your clients are working with. It's very, very effective, and it will really increase their confidence in you as a therapist that you're doing more than just giving a feel-good massage. Ankle sprains are going to be one of the most common injuries that you will be dealing with in a massage practice. Even if people are coming for a nice relaxation massage, they may mention that a month or two ago they sprained their ankle fairly badly or something like that. So let's talk a little bit about how I deal with ankle sprains. And be sure to remember that I've dealt with the ankle, with the retinaculum, with the foot movement in great detail earlier on in these tapes. So whenever throughout this tape that I'm dealing with how to deal with injuries, I'm showing you basic ways to work, and I'm working much faster than I normally would if I were treating someone. I might spend 20 minutes on someone's ankle if they came in with a rather severe sprain from a while back. So do keep that in mind. I'm trying to show you a lot of different ways to work with this. You pick the ways that work for you, and don't try to duplicate the speed with which I'm working here. Basically, there are two stages of treatment for an ankle sprain. The first stage would be the acute stage. I very often have my clients call me, they're panicked, they've just fallen down some steps, and it's a day or so after the accident, and they want work. The important thing about this is that you realize that there's a lot of things that happen on an ankle sprain, and there's the chronic long-term treatment, and then there's the short-term. My basic question that I always ask them first is if they heard a pop. If they have heard a pop, it might be that they've actually torn a ligament here. So that's very important for you to understand. And if we look a little bit closer here to the ankle, I can explain what, probably in 90% of the time, what that pop is right here at the lateral malleolus, which is actually the outside of your fibula here. There's a ligament called the anterior talofibular ligament that goes from the fibula down to the talus bone, and it prevents your foot from inverting. So what happens is 90% of the sprains come from an inversion sprain where the ankle turns to the outside here. So what you will have is that this ligament, if it's torn, will give a loud pop. Now, if it's actually torn, there's probably very little that you can do to fix that. But one of the things that you should be aware of is that that ligament, rather than tearing, can be pulled away from the bone, either at the fibula or at the talus bone. And in that case, it's very, very important to immobilize the ankle so that this ligament can reattach, and then you'll have a very functional ankle. So anytime I've heard there's a pop, I always tell people to go get an x-ray and find out exactly what happened. They may have broken a bone. So that's one of the things you always want to be sure to do. But during the acute stage, your number one thing you're going to want to do is to try to cut the inflammation here, get the swelling down. So that's your basic massage work of effleurage, softening this up, getting some of the smaller adhesions, but basically keeping the ankle in a neutral position. You do want to, as soon as possible, get them back to using this ankle so they don't lose their proprioceptive abilities for balance. And we'll talk about that a little bit later when we combine treatments for plantar fasciitis and for Achilles tendonitis. So I think most of the good we can do as massage therapists has to do with probably helping an ankle that 2 weeks up to 2 months after an ankle injury to return that ankle to proper function. So most of you, I'm sure, have very good skills with doing the effleurage, taking care of swelling, explaining to your clients about icing and elevating and compressing the joint, all the things that you deal with in a sports massage class. What I do 2 weeks to 2 months after an ankle injury is to try to return normal function of this ankle. There's going to be some changes that have taken place. There can be some scar tissue or fibrosity in here. And so we go back to the things we did very, very early of having the client flex their foot up and push it down and see how straight a line does this track on. Somebody with an ankle sprain may be really turned in like this. They may even be turned out. They'll have a lot of jerkiness. And you feel wherever there's restrictions and then just get in there with your fingers. Your knuckles. Work around this anterior talofibular ligament. Try to soften. This will be the area with the most specific soft tissue damage. So do a lot of work spreading, just getting this ankle to work in the right way. Very often I'll come to the other foot and see how does it feel, how does it move, so you have something to compare with. This isn't rocket science. I think a lot of people expect magic tricks to deal with things. The main thing is to be confident in your work, understand the mechanism of injury, and how you can return normal function here. After you've done the specific work around the injury site, then you may want to continue it up the tibia, work on the retinaculum, and just keep testing this ankle. Ask them if there's any positions that this ankle seems to be hampered in or painful in. If you move this foot up and they say, oh, I feel a little catching there, then work in that position. And just basically soften this ankle up and try to return it to the idea of working like a hinge that's able to go up and down. Compare, see dorsiflexion, plantar flexion. Notice if they're limited. Somebody may become very, very limited in their plantar flexion. They may have been walking around with their ankle taped for 2 weeks or 2 months even, or been on crutches, and they've lost this ability to extend here. So you may need to go all the way up the tibia here with tibialis anterior to return this plantar flexion. So always be comparing with the other foot so that you get some balance there. These are the initial ways that I work on the ankle. And we'll talk about doing some work up in gravity when your client is standing. And these are extremely effective ways to return them back to a normal gait. I am going to combine the treatment of plantar fasciitis and Achilles tendonitis in one segment here because the treatments are so similar that I think we can kill two birds with one stone here and move on up the leg to cover all the other things we need to do. A lot of people I have found are really not aware of plantar fasciitis. It used to be called heel spur syndrome, but it is more and more becoming something that massage therapists are aware of as needing treatment, and a lot of massage therapists really don't know how to work with this. So I want to go into the anatomy a little bit. If we can take a look down here at the bottom of the feet. The plantar fascia is this broad fascial sheet that comes down from the front of the transverse arch and attaches at the front part of the calcaneus, right about here. So it comes from a nice broad area down to a rather narrow area. And the calcaneus here can actually have a bony protuberance or a spur here, but those are long-term things, and usually they've been there for quite a while, and certainly it may be a factor, but usually plantar fasciitis is precipitated by some sort of activity that people aren't used to, and everything gets tight and then becomes very inflamed down here. And this is a very, very important condition, particularly with older people, because it can very much disrupt your life as an older person. If it hurts for you to walk around, you stop going out to take your walks, you stop going out and socializing. And I've had very, very good luck with plantar fasciitis, and I do have some rather unconventional things. And when I talk to you about some of the ways I've had success that differ from the conventional Western medicine way, then I will try to alert you so you'll be aware of that. So just picture this broad band of very thick fascia coming down here, and it gets very, very stiff. One of the things that I see is people with very high arches have a much more of a tendency toward this, because when they walk, they've got this fascia stretching each time that arch is asked to be held up. People with flat feet usually have enough mobility of this plantar fascia that it doesn't get stiff. So the first thing I try to do is realize that this is a global issue. It isn't just this fascia right here where it's sore. In fact, you want to keep away from the area of inflammation here and actually work on the other areas so that they're more pliable and flexible and they're not pulling as tight right here where it attaches. So the first thing I do is I try to bend the toes up so that I'm actually working at this fascia clear up here, because it can be exacerbated every time somebody pushes off and bends here. So you need to work globally. So you can use your knuckles or your fingers. The main thing is I'm going to bend these toes up and work. Now I might work for 4 or 5 minutes in this area, but I just want to show you some of the techniques that you would work with this. Certainly grab it with your fingers here. If I want to increase the stretch a little bit, all I would have my client do would be to flex her ankle up, and that's going to stretch things a little bit more. And I just work all the way along here, trying to lengthen this, giving it the ability so that when the foot moves as you walk, that it's not going to be spreading all that strain right down to the sharp little area here of the calcaneus bone. And this is just, again, not fancy work. It's just working within the range of people's comfort and trying to stretch this. This is another example of when you're doing fix-it work that you don't try to do too much at one time. You're much better off having somebody come to you for 15 minutes on plantar fasciitis a couple times a week than to try to do it all at once and flaring it up. And this can really help your practice because you work it into a regular massage schedule and you just spend extra time on the feet. Another way I like to work on this is to bend the knee up, and then I just have my hand underneath and I can do this snowplow idea. So I've got my fingers curved like this. I can again lift the toes up to get a little more stretch on this. And just soften, soften, soften. It's important to educate your clients to both stretch the gastrocsoleus complex and massage the plantar fascia themselves between treatments. It's really not too reasonable to expect one session once a week or every 2 weeks or even twice a week to totally take care of this. They need to start stretching this themselves, and we'll give you some ideas on this. The other area that I like to work on that's extremely important with plantar fasciitis is the posterior compartment. I can't tell you the number of people that I've treated or I've just talked to and say, stretch that posterior compartment and the plantar fasciitis will improve dramatically and even go away. So the main thing I want to do there is I don't want to just soften this gastroc and soleus. I want to put them on a stretch. So we'll go back to the ways we've talked. I can just get my shoulder in here, stretch that foot, get my hands underneath here, and just start lengthening. No fancy tricks here, just get some length to that posterior compartment. And we'll talk about stretches for this in a moment. The Achilles, a lot of people aren't aware that it basically is a tendon that is inside a sheath. So what can happen is that this actual sheath through which this tendon is supposed to slide can be swollen itself and compress the tendon, or the tendon itself can get swollen and compress out against the sheath. So what I try to do is find out where compression is going on and assume that there is going to be some restriction there, and I want to mobilize that so that it can move. So all I would do is find where it's sore, and you have that person help you here. And then sometimes I'll mobilize this way, moving one way or another. And the other is, this was taught to me by a podiatrist about 25 years ago when I was having some Achilles tendonitis. You just grip to the point of discomfort here and then slide that tendon so that you're almost wearing down any cross fibers or adhesions here. And you just keep doing this, and you instruct your client to do this 2 to 3 times a day so that these cross fibers won't build up. Very important to get your clients actively involved in this. You'll find them very, very willing. I think this is the thing that is not covered in initial massage trainings, is that we expect our clients to just relax and we do all the work. And when they come in with problems like Achilles tendonitis, sprained ankles, plantar fasciitis, I find clients extremely willing to help. And the important thing is this gives them a sense of empowerment, that they're not having to depend on you or some doctor to fix themselves. So just you do this 2 or 3 times a day. Explain to them about icing several times a day to cut this inflammation in here and just free up that. You can also come in, I'm going to try to keep my body out of the way, come in below the Achilles tendon here and raise it up. Try to keep it from this tissue down here, which can get very, very tight. If I want to stretch things a little bit, all I need to do is take my knee and bend this, and then I'm going to work on the posterior compartment here. If I feel any specific areas, I can then work with rotation if I feel strain patterns to the outside and inside. We want this to be tracking straight here. If you feel that this calf is rotating this way, pull it this way. Get some freedom in there. Do a raking stroke here. Or you can do an anchor and stretch. If you feel particular tightness right here, you shorten it, anchor up, and then stretch away from that. This treatment would be exactly the same thing you would do for plantar fasciitis. You want to lengthen this posterior compartment here. And this is, again, a nice way to work on plantar fasciitis, is just take your knuckles here and lengthen this. Soften and lengthen these tendons and these fascia. As effective as working on complaints and injuries with your client lying on the table, as effective as those are, working in gravity is a dimension that may take some adaptation for you to get used to yourself, but it can incredibly increase your effectiveness in working with problems that people experience out in everyday life. The problem with working on the table is that it does not approximate what causes the problem in real life. So if you can get your clients to work up in gravity, in walking, in running, and other areas to find out biomechanical issues and to approximate working on those issues while they're standing up in gravity, you can do much, much more work in a very, very little amount of time. And this does move you up into the area of being a real therapist working with problems, so that you can charge more for your work. You'll be getting people referring you to solve individual problems. So let's talk about plantar fasciitis, Achilles tendonitis, and ankle sprains, and give some ways that I would work with my clients after doing the soft tissue work on the table to imprint this in their nervous system and do some fine-tuning so that maybe we can change their gait and some of the injury patterns that have happened as a result of the pain they've had from their injury. So let's take a look at Dina's ankle. And on this, I just get down right on the floor and work with her to try to approximate conditions that cause her discomfort. So let's talk about ankle sprains first. Dina, if we can have you just turn a little bit this way, face me. Okay, so this is the area that so many people, you can work on the table and they're not having any problem, but they get out walking and they start having problems. So what I try to do is approximate the biomechanical situation that causes the problem. So a lot of people, when they're pushing off, this is going to hurt ankle sprains, it's going to hurt their Achilles tendonitis, and it's also going to hurt their plantar fascia. So what I try to do is just have them approximate walking by stepping forward, and then I work on the area as they move through their pattern. So Dina, just pretend like you're walking and raise that foot up and bring your knee forward. That's great. And back down. If I notice that as she's pushing off, her foot is pronating or supinating, then I try to hold it into a neutral pattern. On this one, Dina, I want you to keep your heel on the ground and just bring your knee forward. That's good. So using her gravity, and bring that knee as far as you can forward. Just using gravity in this joint, the weight that's on this joint now that was not in that when she's on the table, can really accomplish a lot. And then I can work on any areas where I feel that her foot is collapsing or rotating, or any areas of stress, or any areas that she says, oh, it hurts right here. Then you say, okay, go ahead and push off that toe just a little bit. That's good. And back down. And push off again. And back down. Can come in here with knuckles, and I just work, this is what I call tracking work, okay, and bring that knee forward again. That's good. And relax back. Okay, so let's do a little bit different here and talk about how we might stretch the posterior compartment and work on the Achilles. So I'm just going to move myself here. Still keeping the same leg, and Dina, just turn just a little bit and step forward with your right leg. Now this is a great way to stretch this posterior compartment in weight bearing. These muscles are going to behave very, very differently in weight bearing than they are on the table. They're going to be trying to approximate how they're going to work in real movement. So I can keep her heel down here and bring that knee forward, and now I'm stretching this posterior compartment here. If a person has Achilles tendonitis and they have specific areas, you can tell them to just push off and bring that heel up. That's it. And relax back down and push up and back down. Lifting this heel up when she's got her weight on that and having to contract these muscles is going to much more duplicate the problems that she's going to feel in real life. I can also expedite that by expediting the shortening and moving in the same direction. That's great. And back down. I actually feel on the medial aspect here a little bit of tightness that may be an old injury that Dina's had. Go ahead and push off there now and really push off. That's it. While she's up there, I'm going to work at this transverse arch. A lot of people that have been limping for long periods of time, they're not able to bring this heel up, and so they lose this whole function of this transverse arch. So go ahead and bring that way up, Dina, and now I just work on this arch here. Get this foot functioning as it's supposed to function. Great. So all of this work on the posterior compartment, you can put that back down there, would be good for Achilles tendonitis work. And remember that for plantar fasciitis, the posterior compartment is very, very important. Okay? So Dina, if you will just turn and face me now, so your back is that way. Let's give the other side a little attention here. This is another great way to work on plantar fasciitis. So just have this foot back a little bit and flex your heel up. And now, and really lift that up. Good. You can see how I'm approximating walking, which is where the plantar fasciitis really hurts anyway. And I'm stretching this. And I'll have her put her weight on her foot as she's walking and just keep duplicating that. Bring your heel down and bring it up. And you'll start feeling patterns that you can see would make this put strain on this plantar fascia. So if you notice that her foot starts rotating this way when she pushes off, you just counter that and start working on this tracking straight. Two or 3 minutes of this work can do what 10 or 15 minutes of work on the table will not accomplish, because you're really working with the nervous system and the way bodies work in real life. The biggest problem you're going to have with this work is adjusting yourself to talk to your clients, to have them put their underclothes on, or finish up the session with their shoes off to work on this. And you will be amazed how many people have never been worked on this way, and your practice will just blossom when you start working this way. And it'll be so much more fun for you. I'm going to cover the shin splint or anterior shin tightness just very quickly here, mostly because I've heard a lot of students that have come into my classes mention that they are not comfortable working here and that they've been told if somebody has shin splints to just not touch that area. So I want to cover some ways of working on this to try to dispel some of those ways of looking at it. So if you take a look at Dina's shin, the most of the problem is going to be right along the front of the tibia and with the tibialis anterior on the lateral aspect here. And what basically is the problem with shin splints usually is that shock is being transmitted up the outside, or that the posterior compartment is too tight, because the tibialis anterior works in opposition to these big, strong gastroconsolius muscles. So if they're very, very tight, anytime you have to raise the foot up, it's working against this and it overworks and becomes stiff and fibrous. So what I do again is I spend a lot of time lengthening the posterior compartment. I'm not going to subject you to watching that anymore, but do continue working along the posterior compartment. Just do nice, gentle work. You've got all these cross fibers that attach the muscle to the bone all the way up the tibia. Even though the muscles lengthen this way, it's attached to the tibia with diagonal fibers. And I just work with the range that the person's able to tolerate it, and I stretch this area out to get some length, and I visualize rolling this tibialis anterior all the way. I've shown this earlier in the tape, so I'm not going to slow down to take that much time on this, but this is the principle you want to do. And you just want to soften this, soften those tendons, so this would almost be a cross fiber stroke on those tendons. Depending on how much they can take, I'm going to do it on Dina's left leg here so my body's not in the way. You can actually just get your elbow right in the crook of your hand here and work up this way too. So you don't have to wear your fingers out, you don't have to wear your knuckles out. This is just slow, easy work. You can anchor and stretch away and soften that. Remember, it doesn't have to have a diagnosis of shin splints. People get very, very tender here. And anytime they're tender and you're working in a regular massage, they say, boy, this is always tender. You feel that. Slow down, work on this area. It's very effective work. Next to lower lumbar pain and disc problems, I think no area strikes fear in the hearts of new massage therapists as much as knee pain. I see a lot of my students that as soon as somebody mentions knee pain, they just totally keep away from the knee and really give up a really good chance to help people significantly. A lot of knee problems have to do with soft tissue stiffness and immobility that put torsion on this very, very complicated joint. So I'd like to talk a little bit about the knee joint so you can understand how it works. So it may give you a game plan when you're planning your strategies on working with knee pain, because they are multifaceted. So let's talk a little bit about the kinds of knee problems that you will encounter. Basically, they are acute or chronic. And acute problems, of course, can turn into chronic problems. But the first long-term chronic problem that I see that rarely has an acute start is patellofemoral. So that has to do with how does the patella track during knee movement. And how does it relate to the femur here? So if there's exceptional tightness almost 90% of the time on the outside of the leg, it's going to pull this patella too far to the lateral side, and it's not going to track straight. So this is a wear and tear, repetitive motion type problem. The next problem that you will encounter, and usually these people will have had this diagnosed by an orthopedist or by their doctor, is that they may have a cartilage problem. Cartilage can either be a wear and tear long-term problem that's finally gotten to the point of causing problems, or it can also be caused by a sudden twist or something like that. So generally, get a skeleton so that you're able to tell if the pain is very, very localized right in the joint line, then very, very possibly you've got a cartilage problem as opposed to a soft tissue problem. And you're going to have less effect on a cartilage problem. You're not going to be able to fix a torn cartilage. However, you can better align the knee by removing strain patterns so that it can move it into an asymptomatic position so that they don't have to have surgery. So I've had some degree of success with minor cartilage tears. The third major cause of knee pain that I encounter in my practice are torn ligaments, and we're going to have the least effect on those, and we have to be very careful with a torn ligament that we don't over-mobilize a knee, because then it will lose its structural integrity. So when somebody tells me they've got a torn ligament that they have not had official Western medicine therapy on or surgery, I tell them that I'll be happy to work with that, help the knee to track, but I don't present a real rosy picture of being able to make a lot of changes. Now, these do overlap. You have to realize that the medial collateral ligament actually attaches to the medial meniscus. So if the medial collateral ligament has been strained, it's very, very possible that it has also caused some damage to the medial meniscus. But as long as you understand these basic types of problems, then you're not going to be frightened when somebody comes in and says they have a torn ligament, or they have a torn cartilage, or they have patellofemoral pain, or jumper's knee, or some of the other titles that are given to that by Western medicine. So let's talk a little bit about the function of this very, very complicated joint. I'm going to try to simplify this a little bit, but until you understand how a knee joint works, it's going to be difficult for you to formulate a plan on how to work with this. So do study this. Play this over several times till you get this concept, and maybe check out a couple books on sports medicine to see some ways of dealing with this. So if we look at the knee, a lot of people just look at it as a simple hinge joint that just opens like this as it flexes and extends. In reality, it's much, much more complicated. The femur and the tibia articulate on two separate articulation points or platforms, and the medial one is actually longer than the lateral one. And because they don't just work as a hinge, they actually slide, and as they move, then since you've got a longer surface here on the inside, you actually have rotation happening. So Dina's helping me by raising her knee when I explain this, and I want to bring in one other factor that you should know, because this is one of the most effective ways to deal with knee pain, is to get this knee working properly so that it can rotate and move. So the major point I want you to understand is that when Dina's knee flexes, This actually the tibia will rotate internally on the femur. So as Dina raises her knee up, this tibia is going to go just like my hand here. Maybe not as much, I'm exaggerating. And as she straightens, it's going to rotate back. So what happens is you've got all these vectors of muscles pulling when she's doing this. If the quadriceps are too tight on the outside, if the vastus medialis is weak on the inside, which is a very common problem for improper knee function. It isn't just tightness, it's weakness on other muscles, and you need to train these muscles. If the hamstrings or the gastrocs are particularly tight on the outside or the inside and are impeding this ability for this tibia to rotate on the femur, then you're going to have strain in the knee. So if you can, rather than just doing broad general work around the knee, if you can decide where are the strain patterns, what's preventing this knee from working properly, then you can do an awful lot of good. You don't need to be an orthopedic surgeon or a chiropractor or osteopath to realize that you can have large effects with these huge muscles that we have here to balance these muscles so that the knee works better. So let's talk about some of the strategies for doing that. Quadriceps and adductor muscles. Notice all the vectors of force acting upon the knee and leg. The ability to locate aberrant strain patterns is very important to provide stability and reduce rotational stress upon the joint. I actually work on the knee in the supine position, probably less than in any other position. I use the prone a little bit more than supine, and I use mostly side lying. This has to do with the fact that primarily tightness on the outside of the knee for the large percentage of the population is what causes knee pain. So I want to make it fairly simple to start. We were fairly technical about the workings of the knee. Now I want to get a little bit more intuitive and a little bit more relaxed about this. One of the first things you can do is just put your hand on when you're putting the lotion on or whatever and feel strain patterns. Is it tighter on the outside? Is it tighter on the inside? Is it more fibrous on the outside or more fibrous on the inside? How does this patella work? Don't be afraid of working with the patella. A lot of beginning classes talk about always staying away from that. It actually feels very good to mobilize the patella. And then you can test, does it slide more easily to the medial or more to the outside? Dina's patella moves a little bit more easily toward the outside, and it seems a little harder to push it over this way. Remember that that patella is not going to slide from left to right if you've got a bend in the knee. That will immobilize that patella. So if you're going to test for patella glide, you want to have your knee fully extended. So then let go of all the specific things that you've been hit with before this, and just let yourself start working on this knee and not be afraid of it, realizing that one of the things you want to do is you want to increase the ability for this tibia to slide on the femur and rotate on the femur. We want more ease in this. Now, if a person has a compromised ligament, then that's not going to be what you're working for. But unless they have ligamental problems or they've told you they're very, very hypermobile, most of the problems I see, probably 75 to 85% of the problems have to do with immobility. So all I would do here is I start thinking about the IT band here. Is it pulling the quadriceps too much this way? Are the quadriceps attached to the IT band here so that they're pulling it this way and it's not pulling on a straight line? Is there more tension here with the hamstrings than with the quadriceps? If the hamstrings are very much adhered to this IT band here, then they may be pulling it this way and pulling the whole compartment that way. I just try to get this whole quadriceps compartment rotating around that bone. So I'm not actually turning her leg in and out. I'm stabilizing her leg, and I may even hold it to stabilize and start working with getting this muscle doing its job. And then again, no special tricks. Just start softening tissue. But you'll notice that my left hand is working to separate these compartments. So this would be one of the separation strokes we talked about way back in the initial tapes. Follow all the way up. In reality, if someone has knee pain, I'll do minimal work in this position and try to get them in side lying as soon as possible. This allows for many more options of knee flexion and extension and better access to the lateral leg. Do remember that the gastrocnemius crosses this knee joint and can be putting strain on it. So we can go back to those old ways we've talked about getting down at the foot of the table and flexing this foot up to get a stretch on the gastroc, and then working from there to lengthen it back here. Consider what are the vectors of strain. How do I get medial versus lateral balance, anterior versus posterior balance? And just do your work. Anywhere where there's tension, have this person work with you. Say, how's this feeling? You don't want to work above, say, 7 on a scale of 10 of what they define 10 as too much pressure. You want to work rather comfortably for them. Don't be afraid to work with all this fascia in here that you feel that's tight. If you feel a little bit of fibrousness, come right underneath that kneecap, work very, very slowly, sink in, pull the kneecap, soften up that tissue. Remember, this is not fancy work. There's no special strokes here. It's just finding tension and softening it. Let's move to the prone position to talk about a few other ways to work on the knee. The hamstring muscles. Originating from the ischial tuberosity, notice how the different attachments of the hamstrings result in very different angles of pull. Always work for balance by determining where stress patterns exist. The hamstrings can easily be as much of a factor as the quadriceps in knee pain. As I mentioned, I actually find the prone position to be more effective in treating knee pain than the supine position. And this is because of all the forces that are on the posterior aspect of the knee that can cause problems, particularly the hamstrings. But one of the first things I do when I have somebody in prone position that has knee problems is I compare each side to see how about those quadriceps? Are they flexible enough? So one of the first things I do is I'll just do a nice stretch. Theoretically, this heel should be able to contact the gluteals. And I also am very clear to tell people if they feel, when I'm stretching this, if they feel pain in the joint itself, to let me know immediately. What we're testing for is quadriceps tightness. So I'll test each side. I know Dina's in pretty good shape here with that, so I'm not going to do the other side. And then you compare. And this sometimes is a way on the knee that's acting up, if it is just unilateral pain, that you can show them, see, you're a little bit tighter on this side. You're going to need to work on that flexibility. I do find an awful lot of tightness in the hamstrings and in the upper gastroc as the areas that are best worked on in the prone position. So I've talked about this before in the earlier tapes, so I'm not going to be spending probably 1/10 as much time as I would actually working. But I again do the same thing we did on the other side. Are the hamstrings tighter on the outside or the inside, or lateral medial? Are the hamstrings tight or the gastrocs tight? And what I feel on Dina that's interesting is her medial hamstrings are much, much tighter than her lateral hamstrings. And I'll see, does it want to rotate one way or the other? So I'm just going to spend most of my time on stretching this medial hamstring. Can you understand, just from what we've talked about, the mechanics of the knee, that if the knee is having to straighten and rotate externally this way as that tibia rotates on the femur, that if she has a very tight hamstring, that's going to be pulling here, and it's going to be preventing her from rotating. So this shows how some specificity and some knowledge of anatomy can really help you, and you're not going to have to waste your time spending 5 more minutes working up here where all the problems here. So all I'm going to do is just stretch this posterior compartment here. I'm working at a very superficial level with my fingers now, working on the fascial patterns that I feel, and then I can get much more specific and be grabbing semimembranosus if I want to, and maybe shortening it if I feel it's too tight, and then doing an anchor and stretch technique. So I'm anchoring here, now I'm stretching right from where I feel any fibrous buildup. And I can continue to do that. I don't have to go all the way down. I just work in the range of motion that I'm feeling it. Softening it by flexing the knee is a good plan so that you can get a little bit deeper here. If I want to stretch the gastrocs, I'll go back to the old technique of stretching the ankle here and moving this way. I'm going to work across Dina's body so my body isn't in the way, but also you'll feel these patterns going all the way up to the hip and the gluteals. So I'll very often get right up here and start working as well. And that's going to affect the knee. Very, very important to work on the upper parts. It's not just that tightness is down there by the joint. Remember, if the hamstrings are universally tight, all you need to do is you go right to the ischial tuberosity here. We've talked about that. You should be able to figure this within, say, 1/4 of an inch of the ischial tuberosity at all times, so you're not having to explore around. And you can just put your hand right there and put your elbow in, and you can get on all of those hamstring tendons and just wait for them. Stretch receptors in those tendons can relax that whole hamstring group in just 30 seconds or so. And this is a good way to very, very gently start working with the ligamentous aspect on that rotation. So I'll just bring the leg up, and I'll just start coming to the end range. I'm sort of exaggerating so you can see what's happening. Feel that. Play around with a little bit of movement. See if I can just get a little bit more mobility on that tibia, and then turn it the other way. Dina's much easier to rotate this way than this. So I'm just going to go to her end point here. I'm not going to force anything. I'm just going to play around with different degrees of flexion. See if I can find a way that I can enable this to rotate a little bit. The main thing is, don't be afraid of working on knees. This is going to be very, very safe work, and your clients are going to feel like you've really helped them. Probably 2/3 of the time, just doing this much work would abate some of the symptoms that people have in knees, and they're going to come back to get more work from you. Okay, don't forget to do some isolation work here and get this idea that these different hamstrings can work independently. So I just do notice a little bit over here on the outside here, a little bit of fibrousness. So I'm just right in between these hamstrings, and I'm working at clarifying these muscle compartments. That way all these vectors can work properly without fighting each other. The side lying position, again, is the best way to work on knee pain or discomfort. I don't think that probably 1 out of 100 people would not feel benefit from work on the IT band. So it's just an amazing strain pattern that passes down from the hips and all the way up the legs. And so virtually everyone I've ever worked on feels benefit from working on the iliotibial band. So let's take a look at its insertion or origin up here. Basically, it originates from the tensor fasciolata, or TFL. And what I'll find with some people is that the TFL, I'm sort of outlining it in the front and the back here, will be pulled too far forward or it'll be pulled too far back. I feel like there's a lot of ease in rotating Dina's TFL to the forward position, but I really feel a lot of restrictions here. So all I would do is I would peel this TFL back and then work along the border to enable it to rotate a little bit posterior here. So don't forget that working on this muscle up here is going to have profound effects all the way down on this big fascial sheet here. So I might work 3 or 4 or 5 minutes softening up this TFL before I move down. I'm not going to take that time because we've got a lot of things to cover, and I've already covered this in the prior tapes. So don't forget the TFL here. Don't forget the external rotators. If they're too tight, all you need to do is bring this knee forward, put them on a stretch, and you can work on these external rotators here. But let's go back here and let's get a little more stretch here. So I'm going to straighten her leg and bring it down and back a little bit and basically just do some nice broad, using the soft part of my forearm, not the bony ulna, and just slowly lengthen this and soften it. Don't feel like you have to make one long stroke all the way down the iliotibial tract. Find out where the tension is and do repeat strokes. It's a long area to be working. You don't want to be working superfluous strokes. Find out where the tension is and do repeat strokes. Tensor fascia lata and iliotibial band. Notice not only the specific well-defined outline of the iliotibial band, but also the superficial fascial sheet. To remove strain on the knee from a tight IT band, it will often be necessary to first do broad lengthening work to stretch and lengthen it, and then do specific envelope work to differentiate the IT band from the hamstrings and quadriceps. Also notice that the gluteus maximus connects to the IT band and can also be a factor in strain patterns. So as we start on differentiating these muscle groups rather than just lengthening and softening, we can see that Dina's IT band is fairly easily defined along the border with the hamstrings and the quadriceps. And what I normally start doing is I start seeing how does it rotate. And if I feel it's bound by the hamstrings, then I may pull it this way and work all along the border. One thing I can do is have Dina straighten her leg as I'm working. That's going to stretch the hamstrings. I can do the same thing on the other side if I feel there's a lot of tightness along the quadriceps here. I'm going to move her leg down so you can see it a little bit more. I can then get right along that border and have her flex her knee. So you can see by bringing her heel back. You can see how that's going to be stretching that quadriceps group. And basically, we're just getting nice, all these vectors that I've talked about that are acting upon this knee, they're going to be working in a nice straight line instead of having all this torsion, being pulled too far forward, too far back, or whatever. So just be sure to do some nice specific work along here, and particularly for athletes, they will really notice this, and they'll come back for multiple treatments. So all of this really translates to more money for you and more successful practice. And then do carry this down beyond the knee a little bit. Side lying position is also another way to just soften this, outline, get right into where tension is, and then lengthen by straightening the leg here. Let's take this top leg and move it forward and put it on the pillow, and just talk about the other factors that are important in knee function. And that would be the adductor group and all of this broad fascial sheet that even though the adductors, many of them don't cross the knee, you can still define this and get this all flowing very, very freely. So same things that we've shown in previous, just outline those muscles, stretch those muscles all the way up to the ramus here, work on these adductors, get some balance between forward and back. She's a little pulled forward here, so I'm going to move in a direction a little bit backwards and just lengthen them. The adductors are very, very important. Remember, as I mentioned earlier in the anatomy, that the medial collateral ligament attaches to the medial meniscus here. So right about here at joint line, if you can soften up a lot of this fascia, separate it basically from the medial collateral ligament, do anything you want. There's no set way of doing that. Just soften this tissue. Then that collateral ligament can work freely without this tension pattern that can be passed on through the fascia here. So do some work right along the knee joint. Don't be afraid of working on that. The other aspect of knee dysfunction that I want to talk about is weakness. Now, a lot of you may not want to get involved with strengthening with your clients, and if you don't, that's fine. But I will say that over the years, simple knee strengthening exercises have been incredibly effective with most of the minor knee pain problems I've had. Because knee dysfunction can be caused by the tight muscles, the things we've just talked about freeing, but it also can be caused by muscles that aren't doing their job of stabilizing the patella or stabilizing the actual joint itself in flexion, extension, and rotation and all the things that people put their bodies through. So I'm going to give you some very simple and safe exercises to suggest to your clients if they're interested in doing this. I am very surprised at the number of clients that say, oh yeah, let me try that. And I've had an extremely high success rate with just the very simplest of exercises that people do for 2 to 3 weeks. The muscles kick in, they haven't been working properly, and they start working properly, and they don't need to continue these exercises. So let's just talk about some very simple strengthening exercises that are very safe for you to suggest to your client. The first exercise I'm going to talk about will strengthen both the hamstrings and the quadriceps group and is extremely safe. All that you need to do is to get a towel roll or some other form of bolster underneath the knee, so there's a slight bend to the knee. You don't want to have too much bend. That would be a little bit too much. So the common bolsters that you see in massage practice are probably a little bit too much. So it's better off to get about 4 inches or so. So there's just a slight bend. And then you have the client keep their heel down and just press their knee down toward the table. Hold for about 5 seconds and relax. Let that joint rest. You explain to them if they're having any knee pain doing this, then not to do the exercises until they can tolerate that. What you might do is have them push a little less hard, experiment with a little more bend or a little less bend to the knee till you can find a range of motion that it's not painful for them to do this, and then extend that range of motion. So give them a rest of 3 or 4 seconds in between and push that knee down. You can see Dina's quadriceps tightening here. So this is a great way to work on this, and relax. At the same time, her hamstrings are contracting to push this leg down into hip extension. So you're getting both of these, and there's minimal movement of the kneecap. The big problem with a lot of the exercises that people give to strengthen the knee is that most of those are active exercises that will be sliding this patella up and down, and that can increase patellofemoral pain. So I'm talking particularly about patellofemoral pain, that you want to keep this knee in a relatively neutral position without a lot of movement of the patella as you strengthen these muscles. So let's move to the next stage. After they've tolerated that, then I added some weight to the equation. What I'm also very careful to do is I only give 1 at the most 2 exercises at a time when I'm giving exercises. You may be giving people the exact exercise they need, and if they get a little bit too advanced and try something else, they may have a flare-up, and you're not going to know what caused the flare-up. So you get some ankle weights. I have an array of ankle weights at my place ranging from 3 pounds to about 10 pounds. And I very often, because people only need to do these exercises for about 2 weeks or 3 weeks, I'll very often loan them to them and tell them that I may have to give them a call if another client needs them. That way they don't have to go out and buy them. So on this, it's important that you get a broad view here, that Dina's back is protected here. If we have her leg down, she can get way too much arch in her back as she's lifting this leg. So I always have the other leg up, bent at about a 45-degree angle here, and that's going to provide her back with stability here. And then I just instruct her to first get a nice isometric contraction. So she's going to tighten that knee as straight as she can, and you can see how these muscles are contracting here. Then she's going to lift that weight about 2 inches and get another isometric contraction, and then she's going to bring it up to 45 degrees. keeping that knee straight, back down, another contraction, and drop. And you're going to repeat this. What generally I have people do in strengthening exercises is to build up to 3 sets of 10. When you can comfortably do 3 sets of 10, then you up the weights. So with somebody that's got a really weak quadriceps group, you may give them a 2-pound weight or a 3-pound weight, and they may only be able to do 5 or 6 reps. That's fine. And they may only be able to do 2 sets. And as they get stronger, and they'll get stronger fairly quickly, then you have them up the weights. So this is very, very safe because the knee is straight all the time, and it's going to be strengthening those muscles. There's a lot of debate in physical therapy about whether these actually work because they don't duplicate the action in real life that causes the problem. But the reality of it is that the patients I give these exercises to do better. So I would suggest trying these if your clients are the least bit interested in doing this. I've had so many runners that have come in that can go out and run 10 miles and are in great shape, but their specific muscles are weak, particularly the vastus medialis, which is the one muscle that stabilizes the kneecap and keeps it from drifting laterally. So you can even have those people turn their legs a little bit, and that medialis has been weak, and then you have them raise it again, and that's going to isolate the medialis a little bit. The third exercise I'm going to give you is called a short arc quad. It's a very short movement that will approximate extending the knee. So again, with weight on, or if they're not strong enough, you can do it without weight. You then, instead of pushing the knee straight down as you did in the first exercise, you keep it where it is and you work toward extending the knee. But it is safest to stop a few degrees short of full knee extension and work up to 3 sets of 10 there. There are a lot of different exercises for knees. I've done a lot of study of this, so I have probably 20 or so that I can isolate and really work well for people. What I would suggest is get that friend that's a physical therapist or an orthopedist or somebody like that that can give you specific exercises and give you some little more specific training if you're interested in this. But strengthening the knee is the other factor that can sometimes be the principle that really solves all these problems, that all the soft tissue work in the world, if you've got a weakness problem, may not solve the problem. So do experiment with strengthening if you're interested in that. The benefit of working around a hip replacement can be profound, especially if the client has protective holding patterns based upon fear. For a more extensive review of restrictions for working with a hip replacement, please view the caveat section of tape number 1. Do remember to not flex the hip beyond 90 degrees. Throughout this series, I've given you a multitude of ways to work with the hips, and I don't want to be too much repeating all of this, except to talk about one issue of working on the hips that I often see my students asking about. And that is the question of how do you work on somebody who's had a hip replacement. And these people can have tremendous benefit from soft tissue work, and a lot of beginning massage therapists exclude work around that area because of fear. So I want to talk about some of the ways that you can work safely on somebody that's had a hip replacement. In my book, I give the example that if you are walking through a dark room and it's one that you're familiar with, you can navigate it very carefully and slowly and make it from one side of the room to the other. But if you're in somebody's apartment or house that you're unfamiliar with and all the lights are off and you have no idea where anything is, it's very hard to work. And this is the way that a lot of people go through with their massage work. If they're unfamiliar with areas, they're tentative and fearful, and that's going to come across. So I want to just talk about hip replacements very quickly to show you some ways not to work with the hip so you can feel safe by mobilizing the hip and giving them some freedom there. The primary movement that the hip is vulnerable with in a hip replacement is in a flexed position adducted, so we're moving this way, and internally rotated. So I'm going to go through this again and do it all at once here. So what you would do if you're moving a hip into flexion and you're bringing this foot out so that you're internally rotating and you're bringing the knee across, that is the most vulnerable position for working on a hip, and you want to keep away from working on it that way. You can, however, do all sorts of work with the knee down into a neutral position. You can work on internal and external rotation. It will be strong in that area. You can even move it back into extension. So I do a lot of work with people with artificial hips by having them turn onto their side. And as long as I don't move this hip into too much flexion, as long as it's back here, I can support this knee with a bolster. You can start extending this hip and getting some movement back into extension. So I do work right along the prosthesis, but not pushing very hard. I'm only pushing about 1 pound here. Nice broad work. And then I just feel for fibrousness. They'll have a scar here, and you can just work right along that scar, right along like this, and you can give a lot of freedom. A couple cautions I might mention on working with hip replacement surgery patients, and that is I would not be doing much heavy work at all for 4 to 6 months after the surgery. You want to make sure they've adapted, that they've encountered all of the problems they're probably going to encounter in everyday life before you impose some extra ones on them. So do wait a while if they've just had this surgery. The other thing is that the procedures out there are broadening, and so the restrictions about internal rotation, flexion, and adduction are not 100% sure that they're going to be exactly usable for you with this client. So be sure to ask your client what positions they feel safe in, and then work in those positions. They will have been instructed by their physician what hip positions to avoid that jeopardize that joint. So do work with that, and realize you're going to be working with a fear factor for these people. They've been laid up for a period of time, off their feet, walking in walkers, and it takes a while to get back that confidence. So just work slowly, always err toward caution, and work with the people. Have a good interchange of conversation going to see how they're doing, and you can give a very, very big gift to your older clients who have been a little bit afraid of walking because of hip problems. Piriformis and deep rotators of the femur. Piriformis syndrome refers to a tight piriformis muscle pressing against or impinging the sciatic nerve to cause sciatica. Note how the sciatic nerve descends near the hip rotators. It may actually run deep to, superficial to, or even through the piriformis muscle. I recently had a referral from a student of mine that I'd recently finished the whole course of deep tissue with, who sent a client to me because the client had been referred by her doctor with piriformis syndrome related to sciatica. And this was disappointing to me because I know that my student was perfectly capable of treating this person, but was a little intimidated with the referral and the diagnosis from the doctor. So even though I've talked about how to work with the rotators and to free the piriformis in our earlier tapes, I'm going to give you a review of this because it is something that's growing in popularity as far as a diagnosis, and it will be something that you will encounter in your practice. So let's take a little look down here at the sacrum and the piriformis muscle. So just to give you an outline from here, my fingers are on the top of the sacrum, and Dina's swimming suit is right around down at the bottom where the coccyx starts. So if I were to draw a line on the sacrum, up from the bottom to the base, which is the top of the sacrum up near Dina's head, and then come right to her trochanter, the piriformis is going to connect right about in the middle of this triangle here. So I know that it's going to be running at a line just about like this. Now the important thing that you need to know is that you are not going to push straight down into the piriformis. That could compress the sciatic nerve and exacerbate the problems. So The first things that I do when I have somebody coming with sciatic or piriformis syndrome is I do try to work above the iliac crest and soften this area to decompress any compression that may be happening in the lumbar area. So I just do some nice slow traction, soften that up. Because sciatica can come from several sources. It isn't just from the lumbar area or just from the piriformis. Tightness in the lumbar area can be sending information down to the gluteals and to the rotators to tighten up so that you've got a complex problem that's got multiple causes. So I would certainly spend maybe 4 to 5 times as much time as I'm doing here. But the basic idea would be I would be decompressing this area. After that, you're not going to get a lot of work done on the piriformis until you've softened up the gluteus maximus. So I'm just going to work through Dina's suit here, but you just would feel wherever there's tension in the gluteus and try to soften it first so that you can sink through it. I think some nice broad strokes first. And I'm trying to grab tissue and stretch it rather than sliding over it. There I felt a little bit of a melt. I'm grabbing that tissue. After that, the fist is a great tool to start working through the gluteus and in a broad way contacting that piriformis. Notice that my fist is soft, and I'm working at an oblique angle. You never want to push directly into the pelvis. That's where you can compress the piriformis and thus compress the sciatic nerve. The sciatic nerve can run deep to, it can run through, or it can run superficial to the piriformis. It varies from individual to individual. So after I've softened this gluteus maximus here, and I feel like I can sink through it, I'm going to come from this trochanter here, right along the line that I'm going to feel for these rotators. And it doesn't have to just be piriformis. And I'm going to sink right through that gluteal, and I can feel these rotators. They're like little fingers coming like this in this direction, and they are a little bit tight. So I'm going to sink in there. Wherever I feel tension, I'm going to wait, work with my client's breath, and wait for a softening. I can do some cross fiber work by moving in this direction. You can see I'm working perpendicular to the direction of the muscle. And this may take 5, even 10 minutes of slow, careful, soft work. Remember, I'm always working obliquely. If I feel my client is starting to get a little bit tired of all this precise work, then I'm going to come out and do some integrative work again. We talk in the early tapes of always trying to cross joint lines, so it might be a perfect time for me to take a nice stroke down the hamstrings and start addressing them and letting them know that I'm going to be coming down there to soften them as well. Now, the next major principle that we've talked about with whenever you're working is the idea of stretching muscles rather than just squeezing them. So let's go back to a little bit more of an anatomy review. I'm going to flex Dina's knee up to 90 degrees here. I'm going to move her leg into internal rotation, which is stretching those external rotators. Now, Dina's external rotators are fairly tight, but they're also fairly long. Somebody with shorter rotators might only go to here. Hers really aren't too short, but they are fairly tight. So what I'm going to do is move to her in range of muscular length. I'm going to move her foot out of the way so you can see this, and then I'm going to sink in to the piriformis again. Gemellus, quadratus femoris, any of these rotators now are going to be put on a stretch. And as this releases, I can continue to move her into more internal rotation. Always check to see how the knee is feeling here. Is your knee doing okay here, Dina?
Fine.
Okay. Now this muscle is probably a quarter to a half an inch longer than it was in a neutral position. Anytime I want to come back out and give that a little rest, if I feel I'm stretching too much, I'll do some nice gentle rocking or something like that. If I want to test the hardness now back in a neutral position, I can actually move her leg into external rotation and I'll feel that muscle softening now. So it's learned to relax a little bit. And now even in a softened position, I find I can sink in here a little bit. So you don't always have that muscle on a stretch. It might be a little much for it sometimes. I'm feeling like I'm making some really nice progress here by shortening that muscle. And now I'm going to bring her leg back out so she's moving into internal rotation. And I'm just grabbing that muscle right through the gluteus and stretching it again. If my fingers start getting tired, I can use a knuckle, but you don't want to use too broad a surface because you're going to have to press too hard to contact it. That's all it is. Again, there's not a lot of magical secret strokes to do with this. I do see a lot of flyers advertising massage that will tell you 1 or 2 strokes to solve this and that problem. I'm not a great believer in that. I think that probably if you can get down there, feel where the tension is, and not make it too fancy and just do that work, that's the best way to do it. So the next thing I want to talk about is if that sciatic nerve has been inflamed by a piriformis or upstream at the lumbar area, the hamstrings are going to be tight. And we all know how to work on hamstrings. The main thing I want to say there is you can do your kneading work, you soften that first, do all the effleurage, all of that, find those strain patterns, see if you can find, whether you rotate internally or externally, find an area that those hamstrings feel like they want to let loose, and then just grab them and stretch them. The problem, it gets to be a vicious circle with piriformis syndrome, is that the hamstrings become tight because of that piriformis and the sciatic nerve being compressed, and then they cause all sorts of torsion on the spine and on the pelvis. As they tighten up, they may pull the pelvis into a different rotational pattern. So you do have to follow through with your work and soften those hamstrings. In probably no other area does the adage, one person's poison is another person's medicine, and one person's medicine is another person's poison, hold true, and in the back. So what I'm going to do with this is to try to get you feeling safe working around relatively severe back problems rather than giving you a large number of strategies to try to fix backs. There are chiropractors, osteopaths, physical therapists, and a lot of other people that have devoted their whole lives to learning about what particular techniques to use with which particular problems. So what I would like you to do is to start feeling safe working with rather severe back problems and giving the people the relief that they can benefit from massage rather than trying to teach you how to fix backs. So let's go down to Dina's back and take a look at some of the things that I try to do to work safely with people with rather intense back pain. One of the first things I try to do is, if I move Dina's arm, you can see I have her pelvis supported with a pillow down below. This is going to stretch out the lumbar area rather than compressing it. Now, this may not be what someone else needs, so what I always do is I check with the person to see how they feel best, how they're the most comfortable. The other thing I always do when I'm working on backs is I try not to have them lying in one position more than about 10 or 15 minutes at the very, very most. Muscles don't like to be in one length. So what I try to do is get my work done fairly quickly, move them to a different position for a while, and then move back to that position if need be. The other thing is, if people have rather acute pain, they're going to be pretty frightened about you diving in right where it hurts. So what I try to do is to work with their fear factor a little bit and work with the areas that are not hurting them. So I've got a fairly good definition of where that pain is, and then I work around there. Then I try to move closer and closer to the pain and see if I can extend the area of non-painful reaction. A lot of problems with low backs have to do with protective splinting that is not actually productive. So what you want to do is walk a little bit of that tightrope on freeing the back without increasing the mobility so much that the back isn't going to be stable. So I take my time, I work down, realizing that I want to move her in 10 to 15 minutes, and then come down to the area. At that time, I'll do some energy work. And this doesn't mean that it's not deep work. She can have very deep holding patterns that if you jostle, if you move the body a little bit, you can feel where those holding patterns are and come down and work with them. Low back pain is a little bit like other reactions of the body that are intended to be helpful to the body that are carried too far. Asthma would be an example of that. Normal allergens in the air are perceived by the body, and the body goes into a panic state and actually harms the individual by overreacting. Well, that can be the same thing with the back. So very often I just try to get this person back in contact with this back, always asking them for feedback if anything I'm doing doesn't feel right, and gain some confidence and increase some circulation here. Don't try to cure low back pain. Try to make the person feel better. After I've done that and I've worked a little bit there and they've gained a little confidence, then I start looking at the pelvis and what forces are acting upon this. I check the hamstrings out. I'm always working globally. If one hamstring is tighter, I might work on it and barely touch the other hamstring. I'm figuring about all of the different vectors that are pulling on this pelvis from above and below that could be compressing or side bending the spine and creating problems. I actually have very, very good luck after I've calmed the back down a little bit to take the pillow out. I'm not going to do that right now, but I have very good luck when they're feeling relaxed. I then take this pillow out, and what I try to do is my major goal on working with back problems is to extend the range of motion or the posture that they're comfortable in. So somebody first coming into you might have a leeway of 5 degrees on extension and flexion before they start experiencing problems. If you can get them down to 7 degrees or 10 degrees, then you've made great progress. I do very little twisting. I've shown a lot earlier about twisting, about mobilizing. I don't do that. One of the best things you can do is just calm down this central nervous system and calm that pain syndrome. If you can make your person feel a little less pain and sometimes be lucky enough to remove the pain if their threshold's fairly close there, then very often they can find what's causing the problem, which is one of the major things I deal with in back work. I try to get the person in a better state so they can find out whether it's getting out of bed in the morning, whether it's driving their car, whatever it is, have them become aware of what's causing the problem. You can't be expected to cure a problem that they're doing day after day, many, many times, that is making their situation worse.